The movement of blood around the body is under the influence of three factors: the pumps of the heart, gravity, and muscular pumps. In a normal active person, these muscular pumps are essential to the process of returning venous blood from the lower limbs to the heart. Let's look at a simplified circuit. The right heart pumps blood into the lungs for oxygenation. The left heart collects the oxygenated blood and pumps it out through the body. Once this arterial blood reaches the lower extremities, the muscular pumps in foot, calf and thigh come into play. They are crucial both in returning blood efficiently to the heart and in the clearance of blood in the capillaries. The calf pump here is an example of how they work. A network of capillaries in the leg feeds into small veins or venules. These in turn lead into the superficial veins. Via the so-called perforators or perforating veins, the superficial veins are themselves linked to the deep veins, which are entirely encased in muscle or between the muscle and bone. All these veins are well supplied with valves, which are integral to the effective operation of a collection and pumping system. In a standing position, the superficial veins act as cisterns. Fluids drain into them via the capillaries and venules. Naturally, pressure builds up. But the blood this superficial system contains, which is only under the influence of gravity, cannot move anywhere until there is a favorable pressure gradient. As the large muscles surrounding the deep veins contract during walking, blood is forced up through the valves within them. At the same time, the valves in the perforating vein are forced closed, thus preventing the blood from returning to the superficial veins. When the muscles relax, the pressure decreases dramatically in the deep veins, creating a favorable pressure gradient and allowing the valves in the perforating veins to open. Blood from the superficial veins can then flow in the direction of the favorable pressure gradient which has been created. Thus, the blood fills the deep veins from the superficial veins, which themselves fill from the venules which are draining the tissues. It's important to stress that the latter process can only happen when the venous pressure falls sufficiently in the deep veins. To monitor the sequence of pressure changes, cannulas were inserted in both deep and superficial veins of volunteers. Here we can see the pressure in the deep veins rise and fall considerably as the muscle activity during walking compresses the veins and then allows them to relax. The yellow trace shows the pressures recorded in the superficial veins at the same time. The pressure differences recorded in the superficial veins were relatively small, and it is only at these points, a time interval of just around 1/10 of a second, when the pressure in the deep vein is lower than that in the superficial vein. At these points, the inflow of blood from the superficial veins is permitted past the valves of the perforating veins, and the blood enters the deep veins. Should there be a dysfunction in the venous pumping system, it's almost always the result of incompetence of the valves. Healthy valves comprise two cusps meeting firmly in the center of the vein. Following the trauma caused, for instance, by thrombophlebitis, the cusps are irreparably damaged. They may also be dilated and the valve become incompetent as a result of occupational or hereditary factors. Where the damage is in a perforating vein, the incompetent valve allows the pressure generated in the deep veins by muscle contraction to force blood back through the perforating vein. As the muscle relaxes and the pressure gradient is reversed, a seesaw effect is created. Simplifying this process and concentrating on the effect in the superficial veins, we can see the increased pressure dilates these superficial veins and causes a different type of valvular incompetence. The cusps here, although remaining healthy, are forced apart. This transfer of pressure from the deep vein to the superficial, with subsequent dilatation of the superficial, continues relentlessly over the years as this disease progresses. Every time high pressure is created in the deep veins, it's transferred to the dilating segment of the superficial vein. As time goes by, so the dilatation of the superficial vein proceeds upwards in a proximal direction, with the vein dilating and each valve in turn showing secondary incompetence. Eventually, after some years, the dilatation of the superficial vein involves either the valve in a higher perforator or the valve at the saphenofemoral junction. At this stage, blood flow patterns change dramatically, with a profuse and rapid downward flow of blood, which on exercise increases in velocity and becomes turbulent as the flow impinges on the vein wall. The turbulence causes atrophy of the smooth muscle in the vein walls, where they're subject to the unnatural turbulent flow, and the characteristic bulges associated with varicose veins become apparent. The effect of walking is to empty the superficial veins through the many still competent perforating veins. This makes room for them to refill rapidly from the gravitational retrograde flow. During the progress of this disease, the original incompetent perforator can be obliterated by ligation, or more easily by sclerotherapy. This involves the introduction of a sclerosant into the emptied segment of the superficial vein over the site of the incompetent perforator, plus uninterrupted compression applied to the injected vein using a rubber pad. Then the leak of high pressure is prevented, and with compression and prescribed walking, the superficial vein will return to normal size and function. Even when the disease has progressed to the stage of retrograde turbulent flow in the superficial vein, the diagnosis and obliteration of the original incompetent perforating vein, together with external compression and prescribed walking, will, in the vast majority of patients, result in the disappearance of varicosity, the restoration of correct blood flow patterns, and the shrinking of dilated superficial veins. Frequently, patients are not referred for treatment until the later stages of the disease, when the effects of downward turbulent flow are apparent. And although we've concentrated here on the effect of just one original incompetent perforating vein, in reality, there may be more to be obliterated for the cure to be effected. The result is that the superficial veins return to their primary function of acting as cisterns. Aided by gravity, they collect blood which is passed into the deep veins through the remaining competent perforating valves. Each time the favorable pressure gradient is created by exercise.